Okay.
Okay.
Well, what's one other case of visceral pain? So we have pain referred from the diaphragm, which is the common one we kind of think of as we see this, because we get that dull, diffuse, achy shoulder pain. It's nondescript. Again, you may find that activity may improve it, or it may just stay consistent. And with your scan exam, you're right. It shouldn't really change the pain process all that much with active, passive, resistive range of motion testing. So, your lack of musculoskeletal findings, would be one of the key things where you think, okay, it's also there. What other questions would you ask if you think, let's say you think it's visceral and it's GI related? What are the classic questions that have been shown to be relevant for this individual to rule in or rule out GI symptoms?
I would ask about bowel movements, any uncomfortable, any blood or anything kind of unusual with bowel movements. Eating meals, right? Does your pain come on, 20 minutes, 15 minutes after eating a meal? Or does it come on directly after eating a meal? So kind of linking, when they're eating and digesting, and if that's going to reproduce pain.
Yeah, what was it with your patient the other day when we were talking about that? I mean, we talked about it yesterday with the patient that I think you and Lauren were seeing. What was his report? Because he was kind of an interesting one, wasn't he?
Yeah, I think he had mentioned some comments about having pain after eating a meal. So we're talking left, pretty much pain kind of right around the lower ribs, and the pain starts there, and then he gets this dull ache in the shoulder. Lauren, correct me if I say anything wrong during this. So obviously the thought Lauren was going through was diaphragm being the problem, but he had also mentioned that he kind of has felt the pain after eating meals that in the past haven't bothered him. So kind of just threw another mixed signal in there that kind of made us rethink that it could be something else besides the diaphragm.
Yeah. I mean, and you can have anything that's going to irritate. You can have a hernia coming through the diaphragm, especially if he has other medical conditions. And that it's still diaphragm related. If you get any type of reflux or some type of hernia coming through there, it may impact how he feels with meals as well. But it is interesting. Did he have any complaint of shoulder pain as well with that? That was kind of his primary complaint, that shoulder pain after meals, or is it more abdominal pain?
Started as abdominal pain. You could always feel it start in the lower, like rib cage and upper abdominal region on the left, and then move to the shoulder.
Okay. Those are the ones that are more helpful when you see the referral pattern, because it starts in the abdomen. Then okay, I'm going to be looking lower. So what else was unique? Because he was unique, wasn't he? What else was unique about this individual?
He does also have cerebral palsy, so he walks a reverse walker, using a lot of like scapular depression, obviously.
Yeah. So I would just ask, how bad was the scoliosis?
I would say mild scoliosis.
Really? Good.
Yeah.
Just think with that, that's the other thing that comes into account too, and why you think diaphragmatic problems, because with this, if he has a marked scoliosis, then again, just where your internal organs are going to sit are going to be different in this individual. The pressure up on the diaphragm, even if you look at chest x-rays, and you'll see that one lung field may be very much larger than the other lung, just by the way his body metric is, and feeling that. And all that plays into, if you're looking at diaphragmatic control, centering and setting positions. So this individual is kind of you have all these other variables coming in. So he's one definitely where you're looking at this viscerogenic pain. It's just very helpful when you have the abdominal pain leading before shoulder pain. Eric, any thoughts on this?
No, I mean, that's probably about as cut and dry of a version of that as I've heard in a while. But you can always look at the type of pain, the descriptors of pain, that kind of deep, achy, poorly localized, all that sort of stuff doesn't really, especially if you're looking at them for shoulder problems, you can always look for the fact that most shoulder movements won't actually irritate it, right? It tends to be more associated with the actual act of eating. And then you can actually do some palpation in that region too, and kind of vary that. So if you can kind of get into the abdomen a bit and find some irritated tissue that'll reproduce some of those responses, that'll give you a little bit of helpful diagnostic criteria as well. And then you could actually have them contract their abdominal muscle to basically create a mechanical block between you and the organs. And if that palpation then diminishes, then, you're pretty much set as far as that stuff goes.
Any other thoughts or any questions, Lauren or Dylan, on your patient? We got Eric here, just so any thoughts. You have kind of my ideas, which I can't say I added all that much to you.
I get nothing new, and I think Lauren and I talked about it detailed, talking with you and Frank, and we've just kind of been repeating the same things, it seems like. So,
okay. Look at that. So cardiac pain, we could talk about it. It's going to be in there, but the cardiac one is, we all know it's the other referred pain that we're going to see, and you're looking at very similar things. You're looking at unaffected by shoulder motion. Shoulder range of motion won't do it. And that idea of that patient not looking well being that sense of pattern recognition. That's a common one you'll hear about it as we start to develop that sense of, you look at this patient and generally they're going to look unhealthy, almost like gray. There's several books that even talk about where, if this is an ICU nurse, they go to a birthday party, they're going to basically be able to tell who basically is going to have some of these cardiac problems just by their physical appearance. They may not even know why, but they're just so used to seeing critically ill people that these nurses will spot them just out in the open because it's just a pattern recognition. If you ask, it's kind of like what we do. It's like if you ask them, we're not quite sure why you see what you see, but it's like, I see this. It's like, but you kind of don't realize the methodology you're using in the back of your mind. And, we don't see a lot of patients with, cardiac disease and shoulder pain, to be honest. They just don't come to us, but it's something that we just want to kind of always, as we do our bias correction, we're going through it. The non-viscerogenic patient without, active, passive range of motion symptoms, then you just want to kind of rethink these other things that may be involved. In cardiac, maybe that one that comes back to you, even if it's not your first one. In that case, your blood pressure, your heart rate, it may not be all telling, but they would be valuable to get at that point, especially if you just need the extra confidence to know that, okay, it is not these structures. Eric, any thought on your cardiac screening?
Yeah, well, the only thing I can think of that you didn't just cover is you have to be aware of some gender-related differences. And, unfortunately, there's actually some race-related differences as well, right? So African Americans tend to have a different reaction to cardiac pain than, kind of the more typical patient that you'd see that the more white-skinned, light-skinned, fair-skinned patients would. Females tend to have more sympathetic symptoms, right? They tend to have more interscapular pain as opposed to the crushing chest pain. They tend to have more of the sweating and those sort of things that'll come about with cardiac problems than males will. So you got to be kind of conscientious of that and very specifically with the triggers for it. Because essentially, the increased discomfort with activity is going to be probably your biggest giveaway. Diabetics are another issue with cardiac problems because they tend to lose some of those nerve endings that'll actually trigger some of the pain responses. So they have, what they call silent heart attacks. So you have to look more at the actual overall kind of health and well-being of the patient, right? Like you were talking about, somebody that just doesn't look well, but that tends to have more difficulties with functioning during in simple activities like walking up and down the stairs, things like that. So those are just a couple of like outliers that you have to kind of consider when you're looking at cardiac stuff. Because I think most healthcare practitioners know kind of the obvious, shortness of breath, crushing chest pain, pain tingling into the left arm. It doesn't necessarily have to be the medial arm, doesn't even necessarily have to only be the left arm. Variances in where the actual heart sits within the chest could cause some of these things to diverge into the right arm as well. Jaw pain, some of those sort of things that'll come about with heart conditions. You have to know that there's some variances there and understand where they come from.
And the next one in the referred category is going to be that spondylogenic pain and neck pain. So, this is the person with, and you start to early recognize the patterns. This person is going to come in and it's going to be more, a superior rounded pain. When somebody comes with rotator cuff pain or shoulder pathology pain, there's usually a point that stands out. There's a motion segment. But that person with that achy, sore shoulder, and they're moving it around and rounding it and going overhead and doing this, and there's no focal point of it. Those are the ones where you start to see them early on. That's my early indicator, because they almost show you in a sense that if there's limited, range of motion findings in the shoulder. Again, it could be mildly provoked and then go away with motion or improve with motion. That's the one you're kind of going to look for there, the spondylogenic pain in the shoulder. And again, it's going to be the idea that, okay, my exam now, the problem is sometimes you do this exam and it's on a 55-year-old man or woman who has, underlying shoulder pathology anyway. You get into, active and passive and resistive testing. They may have shoulder pain with that, but it may not be the finding. Just when you take them to end range and resist, you may reproduce some shoulder pain that's kind of in some degeneration is underlining, which is different than the dull, achy pain that they are reporting with activity. So let's go with Frank. Hey, Frank, what would be the common referral you would think if you're having somebody with achy shoulder pain that's up in here and posterior lateral?
So achy shoulder pain, posterior lateral.
Mm-hmm.
It could be a rotator cuff issue.
Mm-hmm. Yeah, but if it was, let's say, a spondylogenic referral.
Oh, I see what you're saying. Then certainly having some referral from the neck. So I would probably check kind of mid-cervical spine and then CT junction.
Mm-hmm. And how would CT junction refer or create a mid-cervical irritation or refer to it? Would you expect?
So
let's put it this. Both can. I mean, CT junction irritability can refer out and radiate out. I was thinking more in the lines of if you have a CT junction irritation or flexion subluxation, you could irritate the mid-cervical spine. You could then see an extension subluxation somewhere in the mid-spine, which would refer, but that gets kind of tangential with this this one. But you can see that. Eric, do you have a classic pattern for a spondylogenic pain in the shoulder that you typically see?
Yeah, it's very commonly going to be C4-5, maybe C5-6. 4-5 is probably the one that you'd really expect, just because that area you're going to have more of a reference into the lateral shoulder, right, with the C5 distribution. So the C5 nerve root is going to exit between 4 and 5. So I see that mistake made quite a bit, actually, that there people say 5-6, but and if you're looking at potentially a facilitated issue where you're actually getting like a pseudo tendinitis, where it's actually the tension on the tendon that's actually causing the pain. We see that a lot with the lateral elbow. Then again, you'd be looking more at that cuff, but again, it'd be because of the increase in tone across the cuff, as opposed to something where we're actually getting an impingement syndrome, right? So the difficulty with this is, like Dave was saying, you run into the patient that's also has underlying shoulder dysfunction. But if you're looking at somebody that has cervical reference, right, you're going to assume that they likely have some form of segmental facilitation going along with that. That's going to affect all the scapular muscles. It's going to affect, I should take that back. Not all the scapular muscles, but some version of the scapular muscles are also going to be affected. With 4-5, you're also going to get the pec is going to be affected. So all these things are going to affect movement patterns of the scapula and the clavicle, right? So that's going to cause some dysfunctional movements and may cause things like impingement syndromes anyway. Mm-hmm. When I learned all this stuff, the procedure was every time you had somebody come in with shoulder pain, you had to do a cervical scan ahead of time in order to rule that out as a potential cause before you'd even go in and do any examination processes of the shoulder itself. That we've since gone away from that sort of thing because we want to be more specific. We want to be more efficient. So the idea here is doing some sort of screening test for the cervical spine that could rule it in as a potential contributor, right? And so quadrant testing is probably the simplest thing to do there, along with probably rotation testing of the cervical spine as well. Once you kind of have an idea there, if there's significant limitation or significant dysfunction of the movement, right, just an aberrant movement of some kind in the neck, then you can kind of go back and get more specific and do a full biomechanical examination of it. But eventually you're going to want to do some sort of muscle testing, some sort of strength testing, and see if it matches up with a segmental distribution. So you can kind of skip over the whole cervical scan process and use the quadrant tests, rotation tests, and then muscle testing as your screening exam to rule in or rule out the neck as a potential contributor. So that's kind of just the process, but we'll get more into that certainly once we get to module 6, I think it is, when we do the advanced upper quadrant stuff.
And we can touch a little bit on the next slide where it goes into where we're looking at more of the local pathologies, and where this touches into where that spondylogenic, thing where you have mild grade compression on the nerve, creating your segmental facilitation, either creates the breakdown at the motor end plate nutrition, or what you'll see is altered movement patterns in the scapula, creating the impingement or the problem. And it's clear to kind of delineate between, first what we want to do is establish the diagnosis, which this part is about establishing the pathoanatomical, as a word, diagnosis for the individual. And then when you start to look at these other things, that's that search for etiologies. And that's what Eric's talking about. It's like, okay, you get to the pathoanatomical diagnosis, and then the cervical screen then may become, if you think this is a local shoulder problem, then you're back up into the neck to screen for, do I have a segmental facilitation as my potential cause? And then you maybe back up into the neck as, oh, this neck is part of the contributor and part of your etiologies for the rotator cuff syndrome or rotator cuff impingement or biceps tendinitis that's occurring.
Yeah, and you're going to run into these sort of situations, particularly in the shoulder, because of the complexity of it, because you can't just look at the glenohumeral joint. You got to look at the scapula, you got to look at the clavicle, you got to look at the upper ribs, where you're gonna essentially have somebody come in, you're gonna have, take them through some range of motion testing for the arm. You're gonna find limitations, and you're gonna be like, okay, well, what are my likely culprits here? So if you've diagnosed them as having cuff tendinopathies or a biceps tendinopathy, whatever the, pathoanatomical structure that you're dealing with, that's actually the pain producer is, you're going to say, okay, well, where's my likely culprit here? It's, well, you start working from the inside out. Typically, you look at the upper thorax, you look at the movement of the AC joint, and then you look at the movements more specifically of the glenohumeral joint. And you're like, like I said, even if you're dealing with a cervical reference, some sort of cervical involvement, you're very likely to find some sort of upper thoracic limitation that's going to contribute to why the mid-cervical spine has become problematic, right? Because it's this, advanced nociceptive feedback, whether it's actually painful or not, it's this aberrant feedback input that causes these reference pains anyway. So if the upper thorax isn't moving properly, it's going to irritate the neck that's right above it, right? Because most of the movements of the neck, whether it's flexion, extension, or rotations, even side bending, transitions into the upper thorax, right? So you're going to have to compensate for that loss of movement somewhere. So you may go in and actually treat people with, manipulation for the upper thoracic region, for the CT junction. You may go in and treat them around the shoulder girdle, working on the AC joint mobility, clavicular rotations, all of those sort of things. Again, we'll teach you guys all that sort of stuff when we get to module 6. And they may improve, but they may not get completely better, because they also have this thing that's kind of lurking around in there that's also affecting kind of that scapular rhythm, right? So if you're looking at the ability of the scapula to rotate and abduct properly around the thoracic wall, if you have a facilitatory influence with the way that the scapula is kind of anchored onto the trunk, right? We almost look at it like a clock. 3-4 is the levator scap up here in the top corner. And then you move down 4-5 to the rhomboids. And then you move down 6 is the lats. And then you move around to the serratus musculature is 7, right? And so you start getting into this idea that the cervical spine is very well represented in those parascapular muscles. It's not going to allow good mobility, one way or the other. You may have these patients that you're spending time treating kind of the shoulder girdle biomechanical dysfunctions, CT junction, AC joint, et cetera. But eventually you run into a point where they're just plateauing, and now all of a sudden you have to go back and kind of examine the neck. That happens all the time. Are there ways around that where you're not wasting time? There are. Like I said, you can go in and test out some of the motor components, right? The strength, looking for this non-fatigable velocity dependent weakness that may be associated with a facilitation, right? And you can kind of do that without having to worry about some of the regional muscle weakness that you can find. But it gets to be tough. You're essentially sometimes it takes a little trial and error. Sometimes you're looking at it thinking, well, this looks mostly local. This looks like a regional issue. You go and fix that stuff and they just don't get completely better. Okay, no big deal, right? That happens all the time. It's happened to me. I'm sure it's happened to Dave. We can ask Matt if it's happened to him as well. I'm pretty much going to guarantee everybody's had that day in the clinic where it's just like, why isn't this better yet? I've fixed everything that I found. Well, maybe not. Maybe there is something adjacent, something in the cervical spine that's affecting it too. So again, you gotta realize with the shoulder in particular that some of those things will happen. You got to consider the neck. You got to consider everything else that we've talked about. But it's sometimes a process.
If you're not sure in the early going of this, one thing I suggest too is even chat with the patient about when they finish their first session. Chat with them at your plan for the next session. It might be next session when you come in, I'm going to spend a little bit more time, looking at your neck and looking to see is there any contribution from the neck, because when you raise your arm overhead, there's motion at the neck and there's pulling forces. So there can be some influence here. So especially early in the process, just to get your hands on more necks, as it were, it's okay to go ahead and that second time around, I would say go ahead and do an exam on them, or a biomechanical exam. Just let them know in the first session, next time we're going to look at some other things down the line, just to make sure that these aren't contributors. And that one, they'll appreciate your value, that you're looking at more than the standard PT. And two, it's part of your information gathering, because you'll stumble into things just through a matter of process. And eventually it'll be a matter of, it'll be what you do, and you'll just pick up on it like, yeah, I know there's something else going on here. I need to go find it. But until you kind of get comfortable with that process, I just set them up with, here's what we're going to do, here's what I'm going to do, and why I'm going to do it. And they'll see the extra value in it, versus if you just do it to them, if they ask, oh, why are you doing that to me? And you've gotten none of the points or the credit for it, none of the planning process. So, use the environment to your advantage, and use this as well with your patients so that they feel that they're getting the extra value from you as well in the service that you're giving.
And that helps, because you don't want your patient thinking that you're changing your mind as you're going through treatment with them, right? You don't want to. So if you mention that, you say, well, we're seeing some local stuff, and I always treat local stuff before I'll treat spinal stuff anyway, if I'm dealing with something that I'm sorry. The picture of Jim in the corner of all these slides makes me feel like he's sitting there judging me.
I tried harder and harder to get weirder and weirder pictures as time went on. I was trying to pause my screen capture to see, once I had this one, like, can I get weirder faces of Jim?
Yeah, that one looks like he's actually getting ready to yell at somebody.
This was the best. I couldn't outdo this one. I tried, but I couldn't.
It totally distracted me. Anyway, yeah. So I mean, essentially, when you're thinking about etiology, you always want to, and you're not 100% certain, right? You find some local stuff, but you may have some neck stuff that may be contributing, and you just can't tell. Because, like I said, sometimes you'll get this when you're doing. I always use the muscle testing, right? I like to use muscle testing to differentiate between something that's coming from a spinal segment and something that's coming from more of a local issue. But you'll have these kind of combined problems where one will drown out the other. Right. So if you have a local problem around the shoulder girdle, you're probably going to be demonstrating more reflex inhibition around the shoulder, whether or not there's an associated facilitation as well. So you can't be definitive about that until you eliminate one of these things. Right. So the idea that I usually go by is I'm going to go through and I'm going to treat these local things, because if I'm lucky, then I don't have to go open the can of worms that is going into working on the cervical spine. So I'll treat that stuff. I'll see what kind of benefits I can get from that over at least one visit, right? But I'm always going to mention, means functional range of motion, Isaac. Sorry, lost my train of thought again. So the idea is that you mention this at some point. Basically, at the end of your session, you're going to say there is a possibility that there is some contribution from the cervical spine. But what we want to do is we want to eliminate any local or regional biomechanical faults so that we can more definitively diagnose whether or not the cervical spine is contributing. And any good scientist would say you're not going to change every single thing, because if something does really well, you're not going to know which one was actually the reason that it got better, right? Was it the stuff that I did to the local and regional stuff, or was it the stuff I did to the cervical spine? You're tossing up a coin there. So the idea is you eliminate one of these things, you see how they do. If they're doing great, then you may not have to worry about the neck, right? It may not have developed the contribution yet. It may actually improve on its own because you've fixed the upper thoracic issues. So that's the way I go about it. But I like to mention it at the end, because if three visits down the road, I'm going to say, well, I don't need to look at your neck because, we're, at that point, what can I say other than saying, like, we're just not quite where we need to be. So I need to switch gears here. It essentially is like you're admitting that you didn't know what was happening the first few times that they were coming in to see you. And I hate that feeling. I hate having to tell people like, well, we're going to have to switch gears here and do something different because I may or may not have done everything that I should have done initially, even if you did, right? Even if it's just something that was presenting strangely. I like to have that thought in the back of their heads when I finally say, like, okay, we're going to take a look at your neck at this point. Remember, we mentioned this before, but we just want to make sure that it's not something that we have to kind of deal with, on the road to recovery. So good way to look at it sometimes.
Yeah. I mean, yeah, kind of getting into when we talk about point pain and tendon, you generally break down some of your bigger classifications for shoulder pain. I'd say in the local one is labral tear. You have your tendinopathies, which would include tendinosis, tendinitis, AC joint dysfunction, bursitis. Is there any other one in the illness scripts up here that you would think of that would be what are your common tendon issues or common shoulder pathologies or pain generators? You have osteoarthritis, which he mentions in the videos and discusses as well. Okay. And then we're really into, what are your differentiating factors? So if we're down to, okay, we have a local, pain problem, where's the point pain that's going to indicate it? Again, if it's anterior, let's go. Picked on Dylan. Let's go back to Frank. Your anterior, because usually where we're heading initially. Frank, anterior pains in the shoulder. If you have somebody comes in, they point to their anterior shoulder for anterior shoulder pain, what are your differentials there?
So the big ones for me would be probably first one would be tendinopathy. If it's kind of anterior superior, I'm thinking AC joint.
Mm-hmm.
Bursa potentially.
What would you do what other ones? I'll give you biceps tendon as anterior there as well. What else do you have?
You can have some pec irritation. I said AC. You can and then labral things as well. So that wouldn't be necessarily tender, but it would be anterior pain potentially.
Okay. So if you're differentiating, okay, let's say labral tear from AC joint, how would you differentiate those two?
So the big one's location. Typically, AC joint's going to be tender over the joint line. And as I take that arm into that crossbody adduction, it's going to be painful again over the AC joint as opposed to posterior shoulder, posterior capsule.
Yeah.
And then labral tear, is going to be, they're plus or minus, there might be some clicking there. I'll do the labral tests, and there would not be tenderness as opposed to the AC joint. There is going to be tenderness.
Yeah. So again, with the anterior shoulder pain, you're right. Having an AC joint be superficial, being able to palpate it and test it would be helpful. You have Speed's test and O'Brien's test, which either one can be painful with either one. Jim loves O'Brien's test. How do you feel? Do you use O'Brien's test much, Frank?
I do, but not as I wouldn't say I let everything hinge on it, I guess.
Mm-hmm. Yeah.
Just because other things can get it all, can kind of show up as positive.
Yeah. Here's one. As you're reading this, that Jim likes O'Brien's test, and I was going through the literature on it one time, and I saw that Jim's name was on a study on the O'Brien's test one time. So he may have some inherent bias too, based on some of his prior research and publishing on O'Brien's test and why it works. He'll often tell you that if you do the test correctly with medial rotation versus pronation, that your sensitivity and specificity goes up on O'Brien's test.
Okay.
Yeah, and again, I think we have Jenna. Yeah, and I agree with O'Brien's test. It's not as definitive for me because there's also, you can get a positive with AC joint using O'Brien's test as well. So that's the tricky one there, is that if you have pain with it, then you want to qualify where is the pain.
Yeah.
Again, so Jim loves it. If Jim's doing oral practicals and he's doing in clinical reasoning exams, and you have a shoulder case and you're heading down the labrum route, I recommend O'Brien's test. Eric, your feeling?
Yeah, I use O'Brien's test quite a bit, but then again, I learned it from Jim. So
yeah. And many times these tests matter in the hands that they're in. And somebody who's seen, if you've seen a lot of shoulders and you know what you're looking for, and you've seen the difference between what is a rotator cuff, what is a biceps tendon, then the O'Brien's test is more valuable for you because you have the pattern recognition. And I think a lot of these tests, that's what get lost in, is that, you know, in the hands of the tester who uses it a lot, the test is probably more helpful than someone who does not. So tendinopathies, let's go. Tanner Timmerman, I haven't picked on you in months. I feel like you've had a ton of time off. Go a tendinopathy, tendinitis versus tendinosis in the shoulder. What would you expect to see? And the answers are on the screen.
Yeah, I see that. So based off like the videos that I was watching with Jim, my understanding is more like the tendinitis is going to be a lot more inflammatory, so a lot more like point tender as opposed to like the tendinosis. I don't know if that's like an accurate understanding of that. And then with the tendinitis, I would obviously probably expect a little bit more pain with active and then resistive versus the tendinosis. I'd probably expect more pain that's consistent with like resistive as opposed to active. Like I would expect maybe their active is painless, but they have pain upon like resistive testing.
Yeah, it's in general acuity. What you're going to see is that your tendinosis patient will be less consistent. We're talking shoulder, but if we're talking even like elbow, less consistent, maybe in the pain reproduction, where their contractile tests can be positive, or it can be positive and negative, depending where they are in the cycle. Have they warmed up and done something? Have they not done something? If it's a tendinosis. Where your tendinitis with acute inflammation, you're gonna have a much more positive test. You know, small passive things and active range of motion will be more impaired. You know, the pain level of acuity would be higher. I think the irritability level would be higher, as well as what you're going to see with your tendinitis in the shoulder. And for me, I'm also.
And I think.
Go ahead, Eric.
So I was going to say, like, I wasn't able to be on last week, but I watched the video, and Eric, I think you did a really good job of like explaining the fasciosis versus like the fasciitis. And for me, that was super helpful in like helping me understand like the like fasciosis or like tendinosis versus like a tendinitis or a fasciitis. So for me, that was like huge in like my understanding of like how they're going to present in regards to like the different pains. So that was really helpful.
Yeah, it's basically all the same stuff Dave was talking about. I mean, the fasciosis is a little different because essentially if you rest it for long enough, it's going to end up being more painful, versus a tendinosis. It's basically if you have repetitive movements or more consistent use of that structure, that's when it's going to get more irritable, right? So if you test it once, right, you do a contractile test with it once, it may be negative. But if you do it again after making them do a upper body erg thing or something along those lines, or put them on pulleys, and then you test it again, then it might be positive because you've put enough stress on the tissue for it to be irritated at that point. Versus a tendinitis is just going to be sore, period.
All right, so go make the anterior shoulder pain. Okay, if you want a case, we'll stick with you, Tanner. Bursitis. Jim mentions in bursitis, you don't see it as much in the U.S. In CRX old work, like the subacromial bursitis was a much bigger diagnosis than they do in England, which is interesting. And I thought about it for a little bit, and I had a rough answer. Now I don't remember what it was. But I didn't have a good one on why you're going to see it, but what type of repetitive pattern, or why you would see that in an individual with a bursa. And again, if anybody or Eric or even Matt, if you have anything to add to the bursitis versus the tendinitis, I know my implication has been that the advent of MRI and imaging, that most bursitises that they see are accompanied by tendinopathies, as in, the hip being the classic example. But that is not always the case. So if Eric or Matt, I'd be interested in hearing if you guys have any thoughts, or Tanner, if you have any thoughts on the bursitis in the shoulder in your experience, I'd love to hear it.
Well, I mean, for me, there's usually a position where, because the bursa gets irritated because it gets compressed between the tendon and the bone, right, or whatever bony prominence it's protecting said tendon from. There's usually a position you can put the joint in where you actually take you actually slacken that off enough with the contractile resistance that you're not going to get the reproduction of the pain, right? So if you're looking at, you know, a subdeltoid bursitis, for instance, if you test them down here at the side, that's going to be painful because you're going to have tension over the bursa. But if you bring them up into this position, if you can get them into that position with a subdeltoid bursitis, then test them again, it's less likely to be as painful because you don't have as much pressure down on the bursa. There's been some conversation in the past that bursitis will actually be more painful with the release of resistance than it is with the actual resistance. I've never been able to kind of reconcile the anatomy with that. You know, why it wouldn't hurt while you're resisting it and why it would suddenly become painful as you release it. So I wouldn't use that as a diagnostic method personally. But yeah, I mean, those are some thoughts. I mean, essentially you should be able to kind of limit the amount of pain based on the position of the joint before going in and doing that.
Hey, Eric, have you ever just done distraction with the testing? Has that been useful for seeing
For bursitis?
Yeah.
Well, again, it's going to depend on where the bursa lies in relationship to that tendon, right? So if I'm looking at the bursa here in the shoulder and I'm going to just produce like a distraction going straight down, it's not a true distraction, right? I mean, that's going to actually be more of a shearing test because of the position of the humeral head on the glenoid. But can I get irritation of, you know, many of the bursa within the shoulder with that? Probably, because essentially I'm taking that tendon and I'm pulling it down over the bone and compressing it into the bursa itself. So you could do that sort of thing, but essentially that's a passive movement, right? So that doesn't necessarily tell you that it's a bursa, because that would also potentially do the same thing with many of the ligaments of the shoulder, right? Because now it's a passive inert structure potentially that you're moving. And this is part of the reason why bursas are so confusing, because technically bursas are inert structures, right? They do not have a contractile element to them. However, they are so associated with the contractile unit, right? Tendon, muscle belly, etc., that they tend to be painful with contraction, but they can also be painful with passive movements as well, just as we kind of illustrated there. So it makes it a bit more challenging to go through that sort of thing. But I mean, essentially, when it comes down to it, when you're looking at the differentiation between a bursitis and a tendinitis, the thing that you have to really consider is, how do I alleviate the stress on this structure one way or the other, right? Because the structure itself probably isn't the reason that it didn't just decide to become inflamed, right? That's not just the way things work, unless essentially you're dealing with some sort of systemic inflammatory condition, but you're more likely to have multiple body regions that are going to be associated with that sort of thing. So essentially you're still going to be searching for an etiology one way or the other. And so essentially, if you can find an etiology that would tell you, well, this is probably why I'm getting more pressure on either this tendon or either this bursa, if you remove whatever that pathoanatomical limitation is, right? So if you remove the restriction, the hypomobility somewhere within the kinetic chain, then you're probably going to alleviate a lot of the pressure, and the tissue is going to heal up anyway. But when you think about problems like bursitis, like tendinitis, you have to understand the idea of one of the best treatments for a tendinopathy is cross-friction massage, right? That's just one of the best ways that you can help propagate the healing mechanisms here. It also desensitizes some of these irritable tissues. It's not the most fun treatment. It's not the most dynamic thing that we do as manual therapists, but it's one of the most common treatments that we use for things like this. But anything that you're going to use that's going to, you have to essentially consider the mechanism of injury, right? If it's a compressive injury, like an impingement that causes the problem, going in and using a cross-friction massage, which is a pressure technique, may not be the best idea, right? Because essentially you're producing the same force on that damaged tissue that originally caused the problem to begin with. So you got to sometimes consider that sort of stuff, but it can be touchy. I mean, I'm telling you, when you see them in clinic, it can be touchy, but a lot of times it's not going to matter, because the etiology for either a tendonitis or a bursitis is going to be the same thing. And
Yeah.
if you remove that etiology, then you're going to have success with treating the patient one way or the other.
And I agree. That's what they saw with the hip, which they've better been, at least I'm more up to date with the research on that they've seen, is that it's compressive loads that are harder on the tendons versus tensile loads tend to irritate it. So it's compression over the greater trochanter, or is it compression because of the sitting position or a pressure position on the iliotibial band? That's what tends to inflame the tendons and make it worse. So again, speaking to the transverse frictions, you're right. It's not the best choice there. But also they found that with MRI, they had an MRI that most of your trochanteric bursitis, almost all of them, I think all of them basically had a tendonitis element, but not all your tendonitis elements had a bursitis. So anytime you get anybody with a diagnosis of hip bursitis, you can just assume that you have a tendonitis there. And the bursa is there as well. So even though we're doing shoulder here and this process is the same process that gets repeated from ankle to elbow to hip. So going through this is valuable because you're going to see that we're going to continue this process and then apply that region's unique biomechanical and neurophysiological structures to that region to layer on as you go into search for etiologies. But in many ways, your differential diagnosis portion is going to be in these different buckets for musculoskeletal findings. Let's see at the next one here. Ooh, it's a classic Jim here.
It's disappointed Jim right there.
Yeah.
That's somebody giving him an answer in an exam he doesn't appreciate.
Mm-hmm. Yeah, it's right before his whole face pulls up. You ever seen the one where his whole face pulls up? I'll try and capture that for the group. That's a good one too. So I can get that at will. I know. And this is basically taking you through like the differential process. So part of it is that you saw me do it with like Frank is like, hey, or Dylan, it's like, hey, what's your H1? What's your first hypothesis on shoulder pain? So if you have somebody comes in with okay, let's call it anterolateral shoulder pain, and your H1 is tendinopathy, that's what you're going to work through in your differential. So even if we do like an oral practical or in clinic, I don't want to have somebody tell me, oh, well, you have anterior shoulder pain. What's your diagnosis? Well, I think it's segmental facilitation. That'll be a contributor. That's not going to be your differential or H1. So as you go through this one, you're going to see, it's going to be palpation. It's going to be your first go-to. Tell you, Drew, you're out there. I saw you out there earlier. Where are you, Drew?
I'm here.
Cool. You want to talk me through this a little bit? We can go through it together. And hey, Matt, don't be quiet out there, Matt. If you have some stuff to offer, please feel free to chime in. So you got an H1 of tendinopathy in the anterior shoulder. Let's go through this chart here. Let's take a look at what we're going to do after palpation.
Okay, I'll let you know I am on my phone right now, so I can't currently see the chart.
Well, you're of no use to me.
That's such a typical excuse.
Uh-huh.
Man, I'm so disappointed in you. You couldn't have come up with something better than that. Jeez.
Funny. All right, Tanner Newberger, you're up, my friend. Don't tell me you're out walking that dog.
No, we're just sitting inside eating right now.
Okay. Between bites. Okay, you got a H1 of a tendinopathy. Kind of go through here in the mind of Jim. What you're gonna see is, his mind, if you palpate it and it's not tender, or it's tender, what are you thinking first? Let's go tender. You palpate pick the tendon. Which one you're palpating is the most likely one?
Let's just go supraspinatus tendon.
Okay, good. So you palpate and it's tender. Okay, now you go to contractile tests and you can see that it's positive. You can see we're here where that strengthens your differential diagnosis in that aspect. Now, again, there's still a lot left to be done with palpation and not palpation, but differential diagnosis and bias correction. But you get a sense of how you're going to develop an H1 and go through it. Okay, you go through your palpation test and you're not tender on the supraspinatus. So you decide to change your H1 to your H2, which is AC joint dysfunction.
I would, before I do that, I would still do some contractile testing just to see if I can provoke anything.
Yeah.
I wouldn't completely throw it away.
I would too. That's what I recommend. I wouldn't go right to the second one. I would stick with the H1 that you had initially. And I would do the contractile tests and see if I can confirm it or refute it. If the testing then with like shoulders often becomes kind of ambiguous, that's where your bias correction for these other conditions becomes valuable. Because in a sense, you know, it can be dying, and once you feel it's here, and I think this is shoulder, now you can go into these other tests. So I agree. You go through the contractile test. Let's say you go through the contractile test there, and then those come back kind of inconclusive to negative. Then where are you going? Or you get information that's going to give you an H2 of a AC joint dysfunction. What AC joint test?
I could just do a compressive test, see if that brings anything on, and I could still try a little bit of a separation if I squeeze a little bit lower. If you hit the spine of the scapula and collarbone, you can get it to separate a little bit.
Mm-hmm. Yeah, and that's what it's going to be, is that you can palpate the AC joint. You know, I would look for pain provocation test, be palpation. What other tests would you do for the AC joint?
I'd probably toss some type of movement test in there too, see if that provokes any of the pain.
Yeah, I mean, your cross body one is your classic one. That can produce pain in different structures, but you want things that are help to strengthen your differential. Oftentimes, you're going to find swelling if it's an AC joint too. You feel that joint will actually be more palpably rounded, or you feel the fluid around the joint with an inflamed AC joint in there as well. Now, we haven't gone into biomechanical testing of the AC joint, but you alluded to it, and you know, you can check the glides of the AC joint, anterior, posterior, and superior, inferior to see. At that point, I also look at relative motion of the clavicle with shoulder motion. Do I have the clavicle, the AC, the SC joint, and the clavicle moving? Does it have a posterior roll with elevation? Or are you seeing an anterior roll with a shoulder elevation? So you can look at these different functional tests. So they come out negative, and you kind of moved on to your labral tear. And there you're going to go your two tests. Are these the tests you'd use, Tanner, or would you go something different?
One of the ones that I use quite a bit that helps me out is a biceps load 2 test.
Is that a lot too?
Kind of,
if they can get into the position for it.
Mm-hmm.
Correct.
Yeah, the biceps load shift test.
Mm-hmm.
Yeah. Again, I like that one more, and I will do OBriens, but it's always in how you kind of weight it and how these tests are weighted, and kind of many times, again, Jim in some of the earlier presentations, it's really your pre-test probability. It's like, what's your likelihood? So if I'm doing these tests and I don't think I'm just doing it because I'm doing it as part of my bias correction, I don't expect them to be positive, I weight them less. But if I'm thinking this is a labral tear and these tests are positive, then it's kind of supporting what I have to look at.
I think I'm talking about a different test.
Which one are you talking about, Eric?
So a biceps load test, is that the one you said, Tanner?
Yes, biceps load 2.
Oh, I'm sorry.
That's this one up overhead, right?
I read it. I read his as that, but you're right. I see it here now. It's not that one. There's 2 versions of it, correct?
Yeah, there's the 1 and 2.
Yeah. I think that's the one that has the best, more recent sensitivity or specificity numbers as well.
I don't remember the 1. I've only ever used the 2.
Yeah, they're similar. There's a subtle difference in position.
I learned 1 was out at 90 degrees and 2 is up at more like 120.
Okay.
It's really more diagnostic for a slap lesion, right? So like a Bankart tear is not going to be as sensitive for that. Essentially, it has to involve the anchor of the biceps tendon. The tear would have to involve the anchor of the biceps tendon for that test to be relevant.
Here, Jim gets into basically just you kind of rule these things out, and then now you're into the bursa. But what's nice to go through this a bit is, though it's kind of simple in this diagram, is that this is kind of the process that we kind of look for, clinically. Is that, the idea is that we want you to be able to develop a hypothesis, be able to test it, and then you can either confirm it or refute it with the tests that you select. So the idea is that, okay, you're picking tests that are going to kind of help shape it. So the idea is that you come with somebody come with shoulder pain or point pain, And then you have the complete exam with all the tests right away. Because quite honestly, by the time you get 7 or 8 tests, they're all kind of equivocal. You want to kind of develop your hypothesis to say, okay, I can now come in here with an anterior point of shoulder pain, develop an H1 of tendinopathy, and I know how I'm going to test my anterior shoulder pain with tendinopathy. And if that doesn't pan out or isn't strong, I can move on to my H2. Now, what I recommend doing in the early phase with this is, as you do this, let's say I have this person with anterior shoulder pain, I palpate supraspinatus, it is positive. I do the knee or the Hawkins-Kennedy or the shoulder test you like the most, and they're positive. And so you're feeling pretty strong. That's it. You test external rotation, and they're weak in external rotation. But it's not completely failed. So you're feeling pretty good about your tendinopathy diagnosis. Part of your bias correction is then going back, and you can use this process to test, okay, well, what are the competing differential diagnoses? Do I have an AC joint dysfunction? Do I palpate the AC joint? Then does the test become relevant there? So you'll use early on in this as part of your bias, as your bias exam. So you will test these other ones and go through it to make sure that, okay, how do I know I don't have it's not a bicipital tendonitis? And again, or, how can I be less sure it is? Because oftentimes your rotator cuff syndromes is going to have an element of bicipital tendon pain and vice versa because of the shared bursa. They're often inflamed together. So they can be hard to tease out. But you want to get a relative sense of what is the dominant feature in this individual. And you should be able to kind of look at it and think, okay, this isn't a labral tear because I don't have a positive OBriens and my testing is negative. And I do a load shift test and everything is fine. The bursa will be hard to tease out from the tendinopathy. I kind of with Eric in that sometimes it doesn't matter to me because I'm going to have to do similar things anyway, unless it's a really acute hot tendonitis or bursitis and this thing is super inflamed and irritable. And then my choices of what I'm going to do to them is going to be limited. And I may not be worth doing the other tests because I'm going to make them more irritable, as I think Jenna alluded to into the discussion board. So, but what we want from this process is exactly this. In an oral practical or a final exam, part of this is even for the people who are going to be taking it in May, is that this is the differential process that we kind of look for, is that you should be able to develop an H1 on this individual, be able to test your H1. And if your H1 doesn't pan out, then you're going to go quickly to your H2, without much remorse. And it's that idea that you're not anchoring to the first diagnosis in the face of negative tests or evidence that doesn't support it, and to be able to move through these differentials. So Jim in the classic exam, this is exactly what Jim does. He's going to take you through this and he's going to make it sound like a tendinopathy. And then he's going to take away tendinopathy. And you're going to have to kind of go through these list of differentials until he settles on one, which is probably going to be a labral tear, and he'll use the OBriens test. And then after you discover this, now you're into the search for etiologies and looking at what other things would have contributed to this labral tear, since it wasn't an acute fall from a bicycle or a trauma. Does that describe the exam process fairly well? Or even, I don't think about it as an exam process. I want you to think about it as a thought and reasoning process. Eric, anything to add to that?
Yeah, I mean, essentially, when you get really good at this stuff, this is just what's going to go on in your head anyway. Somebody's going to come in, they're going to say, I've got anterior shoulder pain. They're going to point somewhere up here, and your mind should immediately tick off, at least 3 of these sort of things. Biceps tendonitis, AC joint problem, labral tear. Those should be instantaneously in your head. And then your next question should be like, you get any clicking, popping, clunking, anything like that in your shoulder at any point? No. Okay, well, that labral tear goes down the road a little bit, and then you ask, does it bother you with any particular movements of the shoulder, reaching overhead? Yeah, that's the worst part. Like, okay, well, that's probably more likely a tendinopathy than an AC joint dysfunction. Does it bother you if you reach over to scratch your other shoulder, something like that? No, that's not so bad. All right, great. Now I'm into my tendinopathy testing, right? I'll go and palpate it. I'll do my contractile tests. There's a more specific contractile test for the biceps that's, like it mentions over here on the side, look at the biceps tendon of the transverse humeral ligament. There's a way to weed that out between the two. And once I have that, it's just about, what's the etiology? And my process, especially when I'm doing exams, is I'm going to tease you with a bunch of different etiology stuff, right? So the diagnostic process should be pretty simple, should be pretty quick. And then it's going to be about, okay, what could be a potential etiology problem? Well, CT junction issue. All right, show me how you'd examine that. could be an AC joint problem. Okay, great. Show me how you'd show me the biomechanical exam for that. Well, it could be a segmental facilitation affecting it. Great. What's a segmental facilitation? Tell me a bit about that sort of stuff. How's it different from a radiculopathy? All these sort of things. So that's essentially the exam process, but the clinical process, realistically, we want it to be very similar to what we're trying to test for you in the exams, right? These should be the processes you're eventually using in the clinic. So we're trying to make the exams more like the process of somebody coming into the clinic and basically giving you their information. So hopefully, I mean, I think we do a pretty good job of that when it comes to the examination process, but the way that flows, the way Jim has it kind of outlined there, is definitely the way it should work.
Yeah. And that's why when we saw these presentations together, though I'm sorry for the quantity of time that they were, that's why I got them out ahead of time, but you can see how you get this differential process. And then as you get into his next presentation on pain inhibition, reflex inhibition, segmental facilitation, now you're into those etiologies, those things that can also contribute to it, as well as cervical spine. And you kind of sort of build that list of, okay, I have this two-step process to work my way through the differentials, and then I have my search for etiologies, and that's where the treatment really comes in. You know, it's that this is where you're finding those things that, boy, I can really impact some of these variables. I can impact a biomechanical dysfunction. You know, I can change these variables and work through this. You know, so it's just to get a sense of this process, how it goes now as we do it, just so it becomes more natural over time. And again, as much as this is a skills program, you know, we really want to develop the clinical reasoning portion of it, because that's really where you kind of get confidence in the clinic. You feel better about what you're doing, and you're a more competent therapist. I think we're there on time. Wow, that seemed fast. Hope it was as fast for you.
Usually is.
Yeah, I sent those over in Word. I think somebody couldn't open it. I will resend this in a PDF format, because this is just a nice thing to have on hand and just kind of be able to review. His presentations are good. These are ones too that I'm going to try to make a separate list to even go back to in later modules, because Jim usually does these ones in the later modules. He's really brought them up earlier in the program.
I love the falling asleep Jim in this one too.
Yeah, it's a good one.
Can I ask, is Jim's head okay?
Is Jim's head okay?
Yeah.
Internally or externally?
Well, more externally.